Hi everyone, let's consider adenosine. First, the pharmacology, its mechanism of action. What does this drug do? Now, if you're thinking adenosine, that sounds familiar. I've heard this before. You're thinking ATP, adenosine triphosphate. You're exactly correct. Adenosine is found naturally within your body. However, if you take it and you synthesize it and you make it into a drug and you inject it into somebody's vein very quickly in large doses, a couple of cool things happen. As it pertains to ACLS, two areas of the heart that adenosine is going to affect are the SA node and the AV node. What happens is adenosine pumps potassium into the cells and it inhibits calcium, in effect hyperpolarizing those areas of the heart. So adenosine temporarily paralyzes the SA node and the AV node. Now, if you were to temporarily paralyze the whole top half of the heart, what do you think you'd see on a cardiac monitor? Exactly, and that's why we see this characteristic, but usually temporary asystole on the monitor. So, adenosine impacts the SA node by inhibiting the SA node firing, and it inhibits conduction through the AV node. Now, what are we going to use this drug for? Adenosine is the first drug of choice for narrow complex supraventricular tachycardias. Now, these tachycardias are usually caused by a re-entry problem. And what that means is the conduction comes down, gets to around the AV node, and part of the conduction loops back through. It re-enters, it cuts in line and begins another impulse. Re-entry. What we found is that most of the narrow complex SVTs you're going to find in the field, the re-entry point is at the AV node. Groovy. That's where adenosine works, right at the AV node. And that's why adenosine is so effective in treating supraventricular tachycardias. Now, in the real world, you show up, this guy's got a heart rate clipping along 180, 220, something like that, and you really have a hard time discerning, is this regular or irregular? Is this a regular supraventricular tachycardia, or is this an atrial fibrillation with a rapid ventricular response? Because the R waves occur so rapidly next to each other, it's hard to tell if they're regular or irregular. So you give the adenosine, but it doesn't work. Why? Because in AFib, there are other re-entry pathways being used besides the AV node. And the adenosine works on the AV node. It's not going to impact the other re-entry ports used during AFib with RVR. That's why adenosine doesn't work for AFib. Now let's talk about therapeutic versus diagnostic. So far, we've used adenosine as a therapeutic drug. First-line drug for narrow, regular supraventricular tachycardias. But we can use it as a diagnostic drug also, which is the case in ventricular tachycardia. So when we're giving adenosine in VTAC, we're not giving it to treat the VTAC because it won't work for VTAC. Remember, adenosine impacts SA, AV. VTAC is originating in the ventricular chambers where adenosine is not going to work. However, as a diagnostic tool, we can use to discern between VTAC or is this a supraventricular tachycardia with an aberrant ventricular conduction that's making the QRS wide. That's why we give adenosine in VTAC, not to treat the VTAC, to discern between VTAC and SVT with an aberrant conduction. Now, honestly, if your patient's stable, rather than giving him a drug, we can get a 12-lead EKG. Tell us the same thing, and we don't have to pump drugs into the patient. Next, let's talk about some drug administration dosing. Our first dose of adenosine for supraventricular tachycardia is 6 milligrams rapid IV push. Now, if it doesn't convert within a little over a minute, you're going to repeat the dose with 12 milligrams. So 6 milligrams first, repeated by 12 milligrams. Now, some special considerations when administering adenosine. One, the drug has a very short half-life. That combined with the fact that you really have to give a lot of this drug in order for it to be effective. 6 milligrams is a huge dose of adenosine. So, the drug is going to go into the closest IV port to the patient. Downstream the next port, you're going to have a syringe full of saline. Administer the drug and then rapidly administer that saline bolus and push that adenosine to the heart. Okay, so when do you not want to administer adenosine? Adenosine should not be administered in any wide polymorphic ventricular tachycardias. It's been shown to cause deterioration in the patient, hypotension, VFib, bad idea. Thanks for watching. I'm Mark. We'll see you in the next video.